Good morning. This is wonderful to be here. So I'm from Montreal, so excuse some of the gaps that I have around midwifery care and I guess healthcare in general here. So if I say something out of context, please correct me. Today's presentation is Birthing and Nursing the Queer Woman's Way. So I'm going to start by, can everyone hear me well? Yeah? Okay, so how I've defined woman. It's not a typo, but for me it's really how do I integrate a more inclusive way to talk about birth and parenting, and it comes really at a sense, it's womb work. And I also wanted to honor the feminine essence of being a woman. And so spelling woman, W-O-M-B-N, allows me to create this more inclusive terminology and that kind of address the different needs, and at the same time recognizes that if I'm speaking about a trans man giving birth, he's not a woman. It's a person with a womb who has chosen to use it for reproductive purposes. So I'm going to be speaking about people, and they have no fertility problems. These are just, people with egg and sperm. And so everyone that has like fertility issues, I'm kind of excluding it as part of the conversation for today's purpose. Family. And so look at this picture. I'm going to ask you to kind of like turn around to the other people in your table, and we spoke about biases yesterday, and known and unconscious biases. And when you look at this picture, these individuals come into your clinic, what's the first thing that comes into your mind? And I would like to kind of get you to be in conversation and explore what biological family means, what family of choice means, the right of the birthing parent, and racial identity. So if you could just be in conversation for the next couple of minutes with the people around you, and just what are the things that come to you when you look at this picture? Oh, you might know some of these people. One more minute. So do people want to share some of the first, there's no wrong answers, by the way. It's just some of the first thoughts that came to mind and looking at this. So I want to go ahead. Otherwise, I'm going to have to start choosing you. And I will. Five. Thank you. What's your name?
Melissa.
Thank you, Melissa.
Based on context, we assumed they were partners, that they were like coming in being able to live together. Didn't necessarily not be the case, right? If one of them is might not have like a partner or biological support system, and then a really good friend or coming in together.
Okay, thank you. Relationship status. What else?
They could be sisters.
Okay. So they could be sisters, they could be partners. Yep.
Not assuming the extensive involvement of family of choice and the conception story, and whether or not the donor may be involved in that family structure, or whether they may be referred to be removed from the family structure.
Oops. Oh, sorry. Oh, oh. Okay. Yes, so potential presence of a donor, if there's a donor in the picture or not, and how would their involvement take place? What else?
Maybe one of them identifies as a woman, but is actually male.
So one of them might be female identified, or as a woman identified?
Identifies as a woman, but is actually male.
Okay, so yeah. So the gender representation. Any guess who that might be? So who think is the redhead? Yeah, okay. And who thinks it's the blonde?
Nobody wants to make assumptions.
But we have assumptions though. And like I said, it's okay to make them, I mean to say them, like I'm asking you in this context because it's in some way by allowing ourselves to be vulnerable to speak up that we could just say like, okay, we could start kind of question where we're at when it comes to this conversation. And so, yeah, there is no wrong answer. Yes, go ahead.
Yeah, maybe speaking to like that, those inborn sorts of ideas that pop into your head, unacknowledged biases. I think often when we look at photography, we see non-working parents holding and like supporting a pregnant body.
Mm-hmm.
So like this image might default for us that the woman in the foreground, or the person in the foreground, is pregnant, and the person behind is
Mm-hmm.
not.
Yeah. Yeah, that's a very good point. Yeah. So, which also comes into this kind of like that we do live like within this patriarchal model of family structure, and even within, let's assume that they're both women and identify as women, but that there's always one person that's a little bit more masculine, that's the holding things down, and the other one that's more that takes on a feminine role. So even if we have two women in front of us, we unconsciously try to put them within a heteronormative structure to kind of like to just make sense, because that's what we do. We try to make sense of the world around us, and the way that you described it, like in this picture, it kind of makes sense, when we're thinking it in that way. What else? What other thoughts come? What table hasn't spoken yet? The center table? Anyone wants to give it a try? I'm going to have to narrow down by hair color. I mean, both of you say it, like they come in and the first thing you need to just ask and just listen and say, hello, you know, how can I be of assistance? And just the starting point has to be listening to their stories. And regardless of their relationship status, regardless of their gender identity, they will inform you what they're there for. It's obvious from this picture that they care for each other. And so they're coming to you in a very caring and nurturing relationship, however that is defined. Any other thoughts? Sorry. I'm going back. Yeah. So who has thoughts about how they might conceive? Or have you had conversation about how same-sex partners conceive? Do you hear it around you? I don't know the program. I don't know if it's involved. There's much content around it, but yeah, go ahead.
I think it's hard to even do this exercise because we have had some education around it, and you often hear like, wow, it's so inappropriate, other than in the context of being a midwife and asking in a medical setting, but like in general, day-to-day, it's really inappropriate to look at a same-sex couple and go, oh, how did you get that baby? You know? So I think doing that is tricky, but also, and in response to your question, looking into it a little bit and listening to podcasts and stuff, even if it's accessible in Canada, in some ways, it really isn't in other ways. And you can imagine it costs a lot of money, and there's often a lot of international dynamics that come into play in terms of obtaining surrogates and sperm and eggs and all of that stuff.
Right.
So there's a lot of different ways, but it can be very difficult as well.
Yeah. Yes. Thank you.
Yeah, I was going to say, as like folks who are like often seen as like marginalized or feel marginalized within healthcare, going into a doctor's visit or an appointment, you probably already, maybe not, but it's likely that you've already prepped a lot before going. And so I think just maybe not assuming that the people who are in front of you haven't already done a lot of work before they come to see you as well. And so maybe asking folks like how, like, I forget what the question was, but what is their plan? Like, what were they hoping to envision? Like, how did they hope to envision things to go on? Because, like, I guess the conversation would be around like the gametes and like how do you envision like housing the baby, like whose womb? Did you want to use their like whose eggs or like whose sperm? And not assuming that none of those bits aren't like sitting in front of you, like that they want to try or like might not be in the room, and just being open to that scenario with like LGBTQ plus families, that there's a lot of different ways to create family, and sometimes there's people, not everyone involved is maybe as invested in having a family, whereas maybe everyone is, and so that can look different too in terms of numbers and what we've been socialized to know to be the norm of what a family looks like.
Right. So a good way to have the conversation without necessarily asking people about how they conceived or any of that is just what their understanding of family is and how do they identify family. Perhaps their biological family is not in the picture, and that they have an extensive other family of choice who's there and who acts the way a family is supposed to be doing. And so it's a really wonderful opportunity to explore family structures outside of the heteronormative structure, and really and they would tell you, and through that it's just like, well, they say like, well, the donor is a known donor or unknown donor, and then from that you might get into other conversation. For instance, if you have like, in this case, like a multiracial couple, then there's the identity of the child, the racial identity of the child. And that might be a question that they're struggling with. In a sense, it's like, well, if it's the white woman carrying the black child, or the black woman not carrying the child, but it's the white woman who's carrying the child for them, then is it going to be a black child? Is it going to be a white child? Like, it's just, the racial conversation has to take place in a way that maybe in other relationships won't, and which is very personal, you know. And when you're talking about bringing a black child into this world, is like you're setting that child up to potentially be harmed. It's just a fact, whether it was all dealing with systemic racism or just the violence, the physical violence aspect of it. And then what if the relationship doesn't work out, you know? And there's no legal structure in place that allows for the other parent to be involved in it. There's no biological ties to it, but that parent is still the parent. And so they might be coming to you with all of this, and they might be figuring it out, or they've heard stories from their circles. You might know, you might not know, but it's okay to say, I don't know, this is my first experience, but I'm willing to learn with me if you're patient with me and call me out on it. Or I'm just being open to receiving information, being open to learning, but you have to do your homework because they're not there to teach you. They're just a pregnant family, and just like any other family, they're going through the motion, they're having a child, they don't want to educate you. So it's your responsibility to find your resources, your support network, and educate yourself along the way, and just be transparent with your clients. Because they don't expect you to, you know, but when you're uncomfortable, they could feel it. And so you have to kind of work through your own discomfort and really have something in place. What are the rights of non-birthing parents? Have you guys, you had your hands raised a while back. You, yeah, sorry, I don't know your name.
I was, in regards to your last question,
Okay.
I was going to just raise that when we're talking about queering our understandings of relationship and family and parenthood, it's important to remember that we have to queer ideas of monogamy and commitment, and that this might not be a planned pregnancy for either of them. Maybe they didn't go through loopholes, maybe they didn't spend money, and maybe there are also concerns about the rights of the individual who contributed sperm to this in a conflicting manner.
Yeah.
So it's not always that a bunch of money was spent. It wasn't always that we've been fighting this for so long. It may have been a surprise, and maybe something they're now planning for and happening.
Right. Yeah, no, that's very true. It's just you have many people in the picture, and biological rights are real. And they might just come to you and they need help figuring it out because this is their first time dealing with it as well. And if you don't know, don't be afraid to, you know, send them to resources that can. So at the end is, sorry, go ahead.
Yeah, I don't want to talk too much, so I'm going to limit myself to this. But I guess also like the piece that I see some of my friends who are non-binary or like aren't whatever cisgender heterosexual people moving around in the world, those folks, when accessing healthcare of any sort, they're often having to do that job
And so one of the first way that you can check yourself is, or your colleagues, is like what's on the form, like the intake assessment, what's written, and is it an inclusive form that you have, or can someone, by looking at it, feel like there's no space for them there? If it's just like man, woman, that's it. Is there other things within your intake yeah, so just look at your paperwork, and is the staff trained in this area? It's really just don't assume, ask. Be in conversation, be open-minded. We've already spoken about trauma, but I wanted to mention also that I'm going to be touching on it, and so if anyone feels the need for self-care to remove themselves or just stop me, please do. So when we speak of what's best for the baby and what's best for the parent, we talk about skin to skin, for instance, right? And for someone who has a history of trauma, perhaps that is not the best option. And how can you be in conversation with the parent and talk about, well, skin to skin is the best option, but it might not be for you, or just listen. How do you listen to someone who hasn't disclosed their history of trauma? The way I go about it, I just assume that most population has experienced some form of violence. And so it kind of underlines how I listen to what is said and what's not said, and they will let me know. And so you can start around when you're talking about the vaginal exams, and I think you have to do routine exams like during the birth, or part of being regulated, or do you have freeway? No? Okay. Sorry? Okay, but do you have to? Like, is that part of your obligation? Is like you don't have to? Okay, so that's good. So kind of putting that in the option and see how they feel about vaginal exam. And then in the way that they respond, you're able to just get a sense. It's not just a yes or a no, it's just like, are they withdrawing from that conversation physically, just the idea of it. So just look at their bodily response when you're even just talking about vaginal exam. And that would kind of give you one little hint. And you're going to have many other clues along the way towards that. And what I've come across as a lactation consultant is also women who kind of like are frozen around, like they don't feel their breast or one side of the breast and don't know it, or they don't want to nurse, and without really being aware of it, just have a negative association or just want to end the feeding, and then you go through the history and it's just like, oh, okay, that's the place of assault. And then there's this feeling guilty of wanting to continue feeding the child, but it's a place of trauma. So they're triggered every time that the baby comes to them, or there's this association when the baby comes, it's just like it's not a positive experience. And so again, I'm going to ask you to go in your circle and just like, well, what do you do? There's the right of the child. The best option is breast milk. But then you have the parent who's having this experience of trauma and is not even aware of it. How would you respond? So I'm going to give you a few minutes to just talk among yourselves to see how you would address such a scenario. One more minute? Okay. All right. So I'm going to ask a table that hasn't spoken so far to step up. Thank you. What's your name? Thank you, Morgan.
Well, we were just thinking that you may want to, I guess, see if it's actually the baby's, like, at the breast that's what she's unsure about, or if it's just breastfeeding in general. Because if it's the baby at the breast that she's uncomfortable with, maybe pumping could be an option. But if it's just anything around her breast, then she does obviously, she needs to take care of herself. So I know there's lots of studies that say breastfeeding is better than formula feeding, but if formula feeding is still good, if breastfeeding is not an option. So just outlining that she should not formula feed if she's not breastfeeding, and that there, depending on where she is, there's always the option of a wet nurse that's available or something like that.
Yeah. So the first thing is kind of investigate what's actually at the cause, and it's a trial and error, and she might not know. This is the first child, or could be the second child, and was perfectly fine the first time, and the second time around it's coming up for whatever reason. It might be that the birth felt very violating, and so it's coming up this time that it hadn't done previously. So previously it could have been a very positive nursing experience, but this time around, it ended up being in the hospital, and it just triggered a lot of a lot of the trauma, and she's feeling depressed, and people say, oh, it's normal, it's hormonal. That's, some people feel depressed after giving birth, but it's not depression, it's PTSD. So how can you make the distinction between normal hormonal changes that could lead to depression versus it's PTSD as a result of being violated all over again during the birth? And one of the ways is, so you watch the symptoms that come out afterwards, and breastfeeding might be one of them among others. So there's a key investigative role that you have to play. Again, you won't know. You just trial and error and be open to learning, and that is not just one way of doing it. Any other table that hasn't spoken? Or you go ahead.
Well, I was also thinking you raised a very good point, because I think a lot of midwives in this room, and I was assuming if a baby was having too low of a weight, that would be for other reasons, or physiological, or maybe it's just that there's other reasons it's not getting enough milk. So I think it's really important for people to be aware that, for midwives to be aware that it could be, like, if we're not watching her breastfeed, we might not realize that this is actually something as a result of PTSD or trauma. And I think that there's just other reasons why the weight is too low.
Okay. Any other person? What table hasn't spoken? You guys, go ahead.
We kind of discussed whether you said you brought up whether she was aware of the trauma or not. I don't know. That seems to be a situation she was encountering before where you see people dissociate or be very traumatized during breastfeeding when they're not aware of it. Kind of decided that kind of like should we bring it up, should we not? And kind of it would be important to discuss that with her. And it seems like you're being really traumatized this is happening, and this isn't your only option. But kind of discuss the other options with her. So feeding banks or formula feeding option, or if she can't handle constantly breastfeeding, knowing that she can't try to breastfeed if she wants to, that won't be the only way. And then also directing her to resources that can help her with her mental health if she has epidural trauma, to help her through that detailed enough so that she can have a good bond with her child. She can enjoy being with her child. And it doesn't have to be a traumatizing experience every time.
So one of the things that I would encourage you to do then is really name the symptoms that you're observing instead of telling her it looks like she's being traumatized. It's like, well, I noticed that you're kind of shutting off and you're looking away the other direction when when your baby's nursing. How often does that happen? Because it might just be that one time during the visit. Just bringing a mindful practice to the parenting, and so that she knows what's going on. And because you're not going to be around all the time, so you have to be able to give her some of the tools to watch herself, and say like, this is not alarming you, but I am concerned, and the baby's not gaining much weight, and that might be the time to just ask, is there a history of trauma? Maybe during the pregnancy intake it wasn't brought up, or maybe she said there wasn't any, but now she might be open to talking about it. So these are just some of the ideas. Yes, they could nurse. A man can nurse, and the other one was a pregnant man. The second slide, right? So which goes into what you guys are talking about. What are the other options other than nursing at the breast? So the World Health Organization's guideline is really formula is the last option. So I don't even know how many people are aware that if the baby can't nurse at the breast, what are the various ways that they could do that? And that's good to have that conversation prenatal as well, so that the person doesn't feel that they're stuck, like because breast milk is best, and if they don't, then they're a horrible parent. Like, we don't need to guilt any more people into parenting. Like, enough is enough. And so the first option is milk baby at the breast, or chest feeding. So with chest feeding, because they've had a significant reduction of the breast, so generally women who had a breast reduction, their chances of being able to breastfeed is a 50-50 chance. So you have to have in your planning that you have to supplement in one form or another, and you have to watch the baby's weight more closely than you would someone who, for instance, had a breast augmentation. It wouldn't be that much of an issue, but someone who had a breast reduction, you have to watch carefully and have a backup plan. For men who have had like a complete top surgery, it's even harder. So they could feed the child, but it would be like in a limited capacity. Questions? And yeah? Okay. So if they can't, pumping is the second option. So manual expression. The pumps are not necessarily better than manual. Some people can express manually better than the pumps. And pumps also could be just very noisy, very also triggering, or it's just a sound of failure for a lot of women. They're just like, I'm sitting at this machine because I haven't been able to produce adequately. And so it's not necessarily a positive association, as opposed to just pumping is an option because I'm going to work, or it's just a tool that's being used, as opposed to I'm having to pump because my body hasn't been able to produce what's needed for my child. And so the association with pumping or expressing milk, be aware of that. The third option, if they're not capable of doing it or there isn't enough, it's not formula. It is wet nurse. So here, just like if you have a friend, or if you know someone who has had a child, or someone that you trust. And I don't know what the policy is around within your practice around milk sharing. And it will be good to know, because your clients will be asking you. They're just like, well, can I take, my friend just had a baby and I don't want a nurse, can I use her milk? And so inform yourself of what the policy is and the legal ramification of it. But if you're dealing with a population who, it's not going to be possible to feed or express milk, then there has to be a second plan before the formula. So it might be worthwhile as a professional order to just kind of lobby a little bit more around milk sharing and what that looks like. I know in Quebec, there's the milk bank, but it's only available for premature babies. And that's offered through the blood bank. So I don't know what the situation here is, but you need to inform yourself. And then there is, the last option is formula, and there are different types. They're organic, but at the end it's not breast milk, but it's usually, you have to use it the same way as you would use any medication, for instance. So it's a treatment plan along the way that it's a substitute for a small period of time. And so just be in conversation that's with letting the parents know that just because they're having to use supplements for the period of time, it doesn't mean that this is the end of the world. The same way that they would give Tylenol or something else for their child if the child needs it, this is just a supplement to help the child get to be where they need to be. And so just have strategies that are short-term or long-term. So when we spoke about earlier about alternative families, I thought this was a great picture when I saw this. It's just like, looking at this, you wouldn't know if anyone is in a relationship, if who's pregnant, who's not. They could just come to your office and they're like, we want to have a child, or one of us is pregnant and we're raising that child as a collective. So it doesn't have to be a two-parent household. It could be a polyamorous relationship. So this idea of exploring different ways of family structure, this gives us an idea. So don't expect just two people to come in. You could have three people coming in and just like, this is our family, we're having a child together. And there might be legal unions or not. But yeah, that's kind of it. So just to give you, so if you look at this here, this is where you see the scar from the chest reduction, from the breast reduction. And on the right is one of the tools that you would use to supplement. And it's a little bit, it will be harder for the child to latch on to the chest more than the breast because there isn't enough tissue. But the thing is, you do have to ask for help. Like the person needs to be followed by an international board like patient consultant or someone who's knowledgeable enough in that field. But you need to plan for assistance ahead of time. So, I kind of wanted to wrap up what breastfeeding also represents, at least to me. I had trouble with both my kids, and the second time around with my son was stronger. And my bio described that I'm Ethiopian Jewish. And their father is not Jewish. And for me, because my son, the Jewish lineage passes through the mother. And for me, it's just like, well, I have a son who who may be Jewish, who may not be Jewish, like down the line. With my daughter, it's kind of like, okay, she has other kids, so her kids will be Jewish. But with my son, it was really, I had to kind of like make amends. And I had a lot of trouble with the nursing. I hadn't circumcised my son, and I wasn't, so there was a lot of stuff that I was breaking from tradition. And I remember reading a book, Women's Bodies, Women's Wisdom, and there was a passage that was around ancestral wisdom and kind of making amends with that. And so I had like horrible thrush for like 6 weeks. And I just remember reading that passage, and then it just stopped. It just stopped. And for me, it was that realization I needed to come to make peace with my lineage. My ancestors fought so hard to maintain their Jewish identity. And here I was choosing, in a sense, to stop it through my son. So even though the breastfeeding was okay with my daughter, with my son, it came up so much stronger because it represented all the struggles that my family had gone through, and then with one shot, it could have just kind of like ended. And so it forced me to be in conversation with how do I honor my ancestors, my culture, and some of the rituals that I'm willing to be engaged in. And I was able to have that kind of like epiphany because of the difficulty that I had in my breastfeeding experience. And this is a picture of my kids. I took them to South Africa and we went on safari. They had a blast, the whole thing. But their most exciting moment was when we came across an Ethiopian restaurant and they had Ethiopian food. And so that kind of just like, oh, okay, so I'm doing okay then. Like they still find a way to connect to their roots. And the other one is a picture of my daughter at her bat mitzvah. I chose not to have a traditional bat mitzvah, but what I did instead, again, just honoring the idea of her being supported by women. So she had like about a dozen women whom I trusted, and were taking care of her, and we did a ritual, we went to a spa, and so that was for me a way of connecting and honoring our ancestors. So when we're talking about all of this, it's just, yeah, there's a family in front of us, there's the family of choice, but there's also our ancestors. We are not without them. And at the end, all we want is just for the child to be a child. And that's what every child deserves. And whether it's my son who wants to shake his hips, or my daughter, she just wants to be. And that at the end, that's what it's about, the rights, what are the rights of a child. And that's why I advocate for who I do. And I do it by having a circle of women around me with known, visible, and invisible abilities and disabilities, and the idea that we cannot do this work alone, and that your clients need also the support around them. So, thank you. Questions?
Something I really liked in your discussion about like different ways of like making rituals and kind of building meaning in ways that are personal, maybe that are outside of the ones that are most easily accessible to us, like religious sources. I think that's a really good practice.
Thank you. Yeah, thinking outside of the box. That's a queer way of doing it. Anyone else? Okay. While I'm around, if